Welcome. NSG 525. Study section 4. Neurological problems. Introduction. The World Health Organization estimated 2006 that neurologic disorder affects as many as 1 billion people worldwide. A neurologic disorder is any disorder of the body nervous system, the structural, biochemical, or electrical abnormalities in the brain, spinal cord that produce a range of symptoms. You will therefore beam our focus light on neurologic disorder in our community. Learning outcomes. When you have studied this section, you should be able to describe anatomy and physiology of the brain. Explain seizure. Point out epilepsy. Identify stroke. Manage head injury. Review of anatomy and physiology of the brain. The central nervous system is made up of the brain and spinal cord. The brain is one of the most complex and magnificent organs in the human body, which is made up of three main parts. The forebrain, which consists of the cerebrum, thalamus, and the hypothalamus. The hindbrain, which is made up of the cerebellum, pons, and the medulla. The midbrain, pons, and medulla are referred together as the brain stem. The cerebrum is the largest part of the human brain, associated with higher brain function such as thoughts and action. It is divided into 4 sections called lobes. The frontal lobes, which is responsible for reasoning, planning, part of speech, movements, emotions, and problem solving. Parietal lobe is associated with movement, orientations, recognition, perception, and stimuli. Occipital lobe, which is associated with visual processing. Temporal lobe, which is associated with perception and recognition of auditory stimuli, memory, and speech. 2. Seizure. Seizures are episodes of abnormal motor, sensory, or automatic activity. Take 2. Or autonomic activity resulting from sudden excessive discharge from cerebral neurons. Seizure is involuntary alteration of behavior with or without loss of consciousness, accompanied by abnormal electrical discharges in the brain. A sudden episode of abnormal electrical activity in the brain. The International Classification of Seizures differentiates between 2 main types. Partial seizure that begins in one part of the brain, resulting in tingling or twitching of a small area of the body. Generalized seizures involving electrical discharge in the whole brain, resulting in loss of consciousness. Causes of seizures. The underlying causes is an electrical disturbance in the nerve cells, cause them to emit abnormal, recurring, uncontrolled electrical discharges. The specific causes of seizures are varied and can be categorized as follows: idiopathic, genetic developmental defects, and acquired. Causes of acquired seizures are hypoxemia of any cause, including fever, childhood, head injury, hypertension, central nervous system infections, metabolic and toxic condition, e.g. renal failure, hyponatremia, hypoglycemia, brain tumor, alcohol withdrawal, and allergies. Cerebrovascular disease is the leading cause of seizure in the elderly. Nursing management during seizure attack. A major responsibility of the nurse is to observe and record the sequence of symptoms. The nature of the seizure usually indicates the type of treatment that is required. In addition to providing data about seizure, the nursing care is directed at preventing injury and supporting the patient. The circumstances before the seizure: visual, auditory, or olfactory stimuli, tactile stimuli, emotional or psychological disturbances should be noted. Note the position of the head of the beginning of the seizure. This information gives clues to the location of the seizure's origin in the brain. Provide privacy and protect the patient from curious onlookers. Ease the patient to the floor. If possible, constrictive clothing should be loosened. Protect the head with a pad to prevent injury from striking a hard surface. If the patient is in bed, remove pillows and raise side rails. Push aside any furniture that may injure the patient during seizure. Do not attempt to open jaws that are clenched in a spasm to insert anything. Place the patient on one side with head flexed toward, which facilitate drainage of saliva and mucus. Suction if necessary to clear secretions. Do not restrain patients during the seizure because muscular contraction are strong and restraint can produce injury. Nursing management after a seizure. Document the events leading to and occurring during the seizure. Risk for hypoxia, vomiting, and pulmonary aspiration is high. Hence, place patients in side-lying position to facilitate drainage of oral secretions and suction. If needed, to maintain a patient's airway and prevent aspiration, support the patient physically and psychologically. Side dress should be up and padded if necessary to prevent injury. There is usually a period of confusion after a grand mal seizure. The patient on awakening should be reoriented to the environment. If the patient becomes agitated after a seizure, use calm persuasion and gentle restraints. Give oxygen therapy if required. Give prescribed anticonvulsant drugs. Epilepsy. Epilepsy is a group of syndromes characterized by recurring seizures. An epileptic seizure is an episode of neurologic dysfunction in which abnormal neuronal firing is manifest clinically by changes in motor control, sensory perception, behavior, and/or autonomic function. The onset of seizures appears to occur when a small group of abnormal neurons undergo prolonged depolarization associated with the rapid firing of repeated action potentials. Seizures may then spread to involve adjacent area of the brain or through established anatomic pathway to other distant areas. Seizures can be viewed as resulting from an imbalance between excitatory and inhibitory process in the brain. Causes of epilepsy. In most cases of epilepsy, the cause is primarily unknown, idiopathic, or secondary when the cause is known. Although a genetic factor may be involved, in identical twins, if one is affected, there is a 50 to 60% chance that the other will be affected. In non-identical twins, the rate is 15%. If both things are affected, most of the time, they have the same epileptic syndrome, 70 to 19%. Epilepsy can follow birth trauma, asphyxia, neonatorum, head injuries, some infectious disease, bacterial, viral, parasitic, toxicity, circulatory problems, fever, metabolic and nutritional disorder, drug or alcohol intoxication. It is also associated with brain tumors, abscesses, and cognitive malformations. Pathophysiology. Messages from the body are carried by neurons, nerve cells of the brain, by means of discharges of electrochemical energy that sweep along them. Sometimes, due to structural or functional problems, these cells continue firing abnormally and excessively. After attacks are finished, during the period of unwanted discharges, parts of the body controlled by the cells may perform erratically. Normally, brain tissue prevents hyperexcitability by several inhibitory mechanisms. Disturbance in this normal excitability leads to hyperexcitability in this site. In this state, there is increased excitatory transmission of impulses and decreases inhibitory transmission. When these uncontrolled abnormal discharges occur repeatedly, a person is said to have an epileptic syndrome. Classification of epileptic seizure. Seizures are divided into two broad categories. A generalized seizure indicates involvement of both sides of the brain. Partial seizures involve only a localized area of the brain, most common in adults. Partial seizures are subdivided into simple partial seizure if consciousness is maintained lasts for 30 seconds or less. Complex partial seizures result in an impairment of unconsciousness, usually affects the temporal, frontal lobes, and the limbic system. Duration is 1 to 3 minutes. Generalized seizure involves both hemispheres. It is further divided into generalized tonic-clonic, grand mal, in which loss of consciousness is quickly followed by a sudden fall to ground, lasts for 2 to 5 minutes. There is muscle rigidity, epileptic cry, eye roll up or turn to the side, the tongue may be beaten. Absence, petit mal. There is impairment of awareness without warning and ends suddenly. In simply absent seizure, patient only starts turning accompanied by blinking of eyes, dropping of it, or chewing, lasts for 10 to 45 seconds. Atonic seizures. Sudden and total loss of muscle tone and posture, control that causes eyelid to drop, head to nod, and patient to fall to ground, not necessarily associated with loss of consciousness, lasts for 10 to 60 seconds. Tonic seizure, characterized by sudden bilateral stiffening of the body, arms or legs usually last than 20 seconds and are more common during sleep, last for 10 to 16 seconds. Diagnosis of epileptic seizure. Diagnosis aim at determining the type of seizure, frequency, its severity, and the factors that precipitate them. A developmental history is taken, including events of pregnancy and childbirth, to seek evidence of pre-existing injury. The patient is also questioned about illness or health injuries that may have affected the brain. Diagnosis examination include biochemical, hematologic, and serologic studies. MRI is used to detect lesions in the brain, cerebrovascular abnormalities, and cerebral degeneration. The electroencephalogram, also single photon emission computed tomography, is useful for identifying the epileptogenic zone so that the area giving rise to seizures can be removed surgically. Management of epilepsy. The management of epilepsy is divided to meet the needs of each patient and not just manage and prevent seizures. Some develop from brain damage and others are due to altered brain chemistry. Nursing care includes physical and psychological care as well as control of hazards during epileptic attack. Epilepsy cannot be cured, but medication only can control seizures effectively. Prognosis of epilepsy has improved. About 60 to 70% of patients can be expected to achieve complete seizure control following effective monotherapy. Sudden withdrawal of medication can cause seizure. It can precipitate the development of status epilepticus. Examples of drugs used in epileptic conditions include carbamazepine, tegretol, phenobarbital, phenytoin, topiramate, and valproate. 4. Stroke. The brain is essential for condition of all body activities. Hence, impaired blood flow results in altered nutrition and oxygen supply to it, and ultimately compromised function. Thus, stroke is a condition in which rapid loss of brain functions arise due to disturbance in the blood supply to the brain. A stroke happens when blood flow to a part of the brain stops due to an obstruction in the blood flow of the rupture or an artery that feeds the brain that may lead to death of the brain cells. It is sometimes called brain attack. There are basically two types of stroke: ischemic and hemorrhagic. Stroke is a sudden loss of neurological function resulting from focal disturbance of cerebral blood flow due to ischemia and hemorrhage. Signs and symptoms often develop suddenly and without warning. It also depends on the parts of the brain that is damaged. Some of these include headache, difficulty in swallowing, reading or writing, incontinence, loss of memory, inability to speak, muscle weakness, numbness or tingling on one side of the body, even paralysis. Common investigations done include angiogram of the head, carotid duplex ultrasound, MRI, CT scan, echocardiogram, magnetic resonance audiography, blood cholesterol and sugar level, complete blood counts. Treatment of stroke is often dependent on the cause and severity. It is a medical emergency and can cause permanent neurological damage, complications, and deaths. Primary prevention is the key to reducing the burden of the disease. Stroke is the leading cause of morbidity and mortality worldwide and is likely to worsen in developing countries over the next 2 decades based on the projections by the World Health Organization. Nigeria, the most populous black nation in the world, stands to risk the further straining resources as a result of the cardiovascular disease due to epidemiological transition. The current prevalence of stroke in Nigeria is 1:14 per 1,000. Though the incidence and prevalence of stroke have not been established in Nigeria, however, a report from a stroke registry in Ibadan gave the annual incidence of stroke in Nigeria as 26 per 100,000 populations. Most recent reports suggested an increasing incidence, but because there were hospital-based studies, they could be accurate. According to AHAP 2008, the frequency of stroke in hospital populations varies from 0.9% to 4%, whereas among neurological admissions, stroke accounted for 0.5% to 45%. Stroke was recorded as the commonest cause of neurological and medical admissions in the Lagos University Teaching Hospital and the Ogun State University Teaching Hospital, respectively, WAP 2008. At the University College Hospital Ibadan, LUTH and OSUT, stroke accounted for 5%, 8% and 17% respectively of medical deaths. Therefore, stroke appears to be a huge problem in Nigeria and places a major financial burden in the adequate health services in the country. In Nigeria, cerebral ischemia accounted for 64%, intracranial hemorrhage and subarachnoid hemorrhage for 6% of all strokes. However, more recently, a changing pattern with an increasing frequency of hemorrhagic stroke has been suspected. According to the internet Stroke Cancer 2012, stroke is the third leading cause of death in the United States. More than 140,000 people died from stroke in the United States. It is the leading cause of serious long-term disability in the United States. Each year, approximately 795,000 people suffer a stroke. About 600,000 of these are first attack and 185,000 are recurrent attacks. Nearly 3/4 of all stroke occurs in people over the age of 65 years, although it can occur at any age. The death rates are higher in African Americans than for whites. Even at younger age, the risk of ischemic stroke in current smoker is about double that of non-smokers. Atrial fibrillation is an independent risk factor for stroke, increasing risk about 5-fold. High blood pressure is the most important risk factor for stroke. Studies have also shown that stroke is a significant economic, social, and medical problem. Types of strokes. Strokes are classified majorly into two major categories: ischemic and hemorrhagic. Lewis, Kemper and Dixon, 2011. National Institution of Neurological Disorders and Stroke, 2009. An ischemic stroke, or what is now being termed brain attack, is a sudden loss of function resulting from disruption of the blood supply to a part of the brain. This eventually leads to dysfunction of the brain tissue in that area, usually caused by large artery thrombosis, small penetrating artery thrombosis, cardiogenic embolic, atherosclerosis, or idiopathic. An ischemic stroke can occur in two ways: embolic and thrombotic strokes. Embolic stroke. In an embolic stroke, a blood clot forms somewhere in the body, usually the heart, and transverses through the bloodstream to your brain. Once in the brain, the clot eventually travels to a blood vessel small enough to block its passage. The clot lodges there, blocking the blood vessels and causing a stroke. This type of blood clot is termed an embolus. Thrombotic stroke. In the second type of blood clot stroke, blood flows is impaired because of a blockage to one or more of the arteries supplying blood to the brain. The process leading to this blockage is known as thrombosis. Blood clot stroke can also happen as the result of unhealthy blood vessels clogged with a buildup of fatty deposits and cholesterol, atherosclerosis. The blood requires this buildup as multiple, tiny and repeated injuries to the blood vessel wall. Thus, the body reacts to these injuries just similar to bleeding from a wound by forming clots. Two types of thrombosis can cause stroke: large vessel thrombosis and small vessel disease or lacunar infarction. Large vessel thrombosis. Thrombotic stroke occurs most often in the large arteries. So large vessel thrombosis is the most common and best understood type of thrombotic stroke. Most large vessel thrombosis is caused by a combination of long-term atherosclerosis followed by rapid blood clot formation. Thrombotic stroke patients are also likely to have coronary artery disease, and heart attack is a frequent cause of death in patients who have suffered this type of brain attack. Small vessel disease or lacunar infarction. Small vessel disease or lacunar infarction occurs when blood flow is blocked to a very small arterial vessel. The term's origin is from the Latin word lacuna, which means holes, and describes the small cavity remaining after the products of deep infarct have been removed by other cells in the body. Little is known about the causes of small vessel disease, but it is closely linked to hypertension, high blood pressure. Hemorrhagic stroke. Hemorrhagic stroke is usually caused by the breakage or blowout of a blood vessel in the brain. Hemorrhagic strokes account for 15% of cerebrovascular disorders and are primarily caused by an intracranial or subarachnoid hemorrhage. Smethers et al. 2010. Hemorrhagic strokes are caused by bleeding into the brain tissue, the ventricles, or the subarachnoid space. Primary intracerebral hemorrhage from a spontaneous rupture of small vessels account for approximately 80% of hemorrhagic strokes and is primarily caused by uncontrolled hypertension. Intracerebral hemorrhage. Smethers et al. 2010 identifies intracerebral hemorrhage or bleeding into the brain substance. It is most common in patients with hypertension and cerebral atherosclerosis because the degenerative changes from this disease cause rupture of the vessel. They also may be due to certain types of anterior pathology, brain tumor, and the use of medications, oral anticoagulants, amphetamines, and illicit drugs such as cracks and cocaine. The bleeding is usually anterior and occurs most commonly in the cerebral lobes, basal ganglia, thalamus, brainstem, mostly the pons, and cerebrum. Cressy et al. 2001. Occasionally, the bleeding ruptures the wall of the lateral ventricle and causes intraventricular hemorrhage, which is frequently fatal. Intracranial cerebral aneurysm. Intracranial hemorrhage is the accumulation of blood anywhere within the skull vault, which could be intra or extra-axial. The former refers to blood inside the brain, while the latter describes blood inside the skull but outside the brain. Intra-axial hemorrhage is due to intraparenchymal hemorrhage or intraventricular hemorrhage. Blood in the ventricular system. The main types of extra-axial hemorrhage are epidural hematoma, bleeding between the dura mater and the skull, subdural hematoma in the subdural space, and subarachnoid hemorrhage between the arachnoid mater and pia mater. Most of the hemorrhagic stroke syndromes have specific symptoms, e.g., headache, previous head injury. Smethers et al. 2010 describes an intracranial cerebral aneurysm as a dilation of the walls of a cerebral artery that develops as a result of weakness in the arterial wall. The cause of aneurysms is unknown, although research is ongoing. An aneurysm may be due to atherosclerosis resulting in a defect in the vessel wall with subsequent weakness of the wall, a congenital defect of the vessel wall, hypertensive vascular disease, head trauma, or advancing age. Subarachnoid hemorrhage. And a subarachnoid hemorrhage into the subarachnoid space may occur as a result of an intravenous malfunctions, intracranial aneurysm, trauma, or hypertension. The most common cause is leaking Take 2. The most common cause is a leaking aneurysm in the area of the circle of Willis or a congenital AVM of the brain. Etiology or causes of stroke. 2. A stroke occurs when the blood supply to the brain is interrupted or reduced. This deprives your brain of oxygen and nutrients, which can cause the brain cells to die. A stroke may be caused by blocked artery, ischemic stroke, or a leaking or burst blood vessels, hemorrhagic stroke. Some people may experience a temporary disruption of blood flow through their brain, transient ischemic attack, ischemic stroke. About 85% of strokes are ischemic strokes. Ischemic strokes occur when the arteries to the brain become narrowed or blocked, causing severely reduced blood flow, ischemia. The most common ischemic strokes include thrombotic stroke. This occurs when the blood clot thrombus forms in one of the arteries that supply blood to your brain. A clot often may be caused by fatty deposit plaque that build up in the arteries and cause reduced blood flow, atherosclerosis or other artery conditions. Embolic stroke. This occurs when the blood clot or other debris forms away from the brain, commonly in the heart, and is swept through the bloodstream to lodge in narrow brain arteries. This type of blood clot is called an embolus. Risk factors. There are many factors that predispose one to stroke. These include high blood pressure, most important modifiable factor, diabetes, family history of stroke, high cholesterol, age 35 and 55 above for women and men respectively. Race, higher in blacks, smoking, obesity or overweight, alcohol, drugs, e.g. cocaine. Pathophysiology. Stroke is a sudden loss of neurologic function resulting from focal disturbance of cerebral blood flow due to ischemia or hemorrhage, mass and Savger 2009. The cerebral circulation. The brain is supplied by two pairs of arteries, the internal carotid arteries and the vertebral arteries. The carotids supply the anterior portion of the brain, including most of the cerebral hemisphere except for the occipital lobes, while the vertebra articulates to form the basilar artery and supply the posterior portions of the brain, including the cerebellum, brainstem, and occipital lobes. The anterior and posterior circulations articulates are the circle of Willis. There is need for the brain to receive steady supply of oxygen and nutrients from the blood since it has no oxygen or glucose storage capacity. Hence, there is a pertinent need for steady blood supply to the brain tissues. Lewis et al. 2011 opines that this blood flow must be maintained at a steady rate of 750 to 1000 milliliters per minute or 20% of cardiac output for optimal brain functioning. Additionally, when there is total interruption of cerebral blood circulation, neurologic metabolism is altered in 30 seconds. This metabolism stops in the 2 minutes and cellular death results in 5 minutes. In an ischemic brain attack, there is disruption of the cerebral blood flow due to obstruction of blood vessel. This disruption in blood flow initiates a complex series of cellular metabolic events referred to as ischemic cascade, which include inadequate adenosine triphosphate, loss of ion homeostasis, free radical, and cell death. The ischemic cascade begins when cerebral blood flow falls to less than 25 ml per 100 gram per minute. At this point, neurons can no longer maintain aerobic respiration. The mitochondria must then switch to anaerobic respiration, which generates large amounts of lactic acid, causing a change in the pH level. This switch to less efficient anaerobic respiration also renders the neuron incapable of producing sufficient quantities of adenosine triphosphate to follow the depolarization process. Thus, the membrane pumps that maintain electrolyte balances begin to fail and cells cease to function. Each step in the ischemic cascade represents an opportunity for intervention to limit the extent of secondary brain damage caused by a stroke. However, some medications that protect the brain from secondary injury are called neuroprotectants. The pathophysiology of hemorrhagic stroke depends on the cause and types of cerebrovascular disorder. Symptoms are produced when an aneurysm or AVM enlarges and presses on nearby cranial nerves or brain tissue, or more dramatically, when an aneurysm or AVM ruptures, causing subarachnoid hemorrhage into the cranial subarachnoid space. Normal brain metabolism is disrupted by the brain being exposed to blood, by an increase in ICP resulting from the sudden entry of blood into the subarachnoid space, which compresses and injures brain tissue, or by secondary ischemia of the brain resulting from the reduced perfusion pressure and vasopressin that frequently accompany subarachnoid hemorrhage. A major variety of manifestations resulting from impairment in voluntary perception and coordination can be devastating. The upper motor neurons are destroyed. Usually, the decussating upper motor neuron results in manifestations on the opposite side where the lesions exist. Usually, epiplegia or hemiparesis is the major sign. In the acute stage of apoplexy, flaccid paralysis, and decrease in the deep tendon reflexes are present. The deep reflexes reappear within 48 hours and followed by spasm, abnormal increase in muscle tone of the extremities on the affected side. Communication loss or impairment such as dysphagia, dyspraxia or apraxia and apraxia are possible manifestations. These are due to paralysis of muscles involved in speech production. Dysfunction of perception is mostly seen in disturbances of visual cortex such as homonymous hemianopia, loss of half of the visual field. Urinary incontinence or retention may result when the urinary bladder becomes atonic and lose ability to respond to fullness or loss of control of external urinary sphincter. Conclusively, when a stroke occurs, all the body functions that are dependent on the affected part of the brain are affected. General manifestations include hemiplegia, hemiparesis, flaccid paralysis, dysphagia, apraxia, difficulty interpreting tactile stimuli, forgetfulness, urinary continence. Comparison of left and right hemispheric stroke manifestation, adopted from Spencer et al. 2010, Lewis et al. 2011. Left hemispheric stroke. Paralysis or weakness on right side of the body, right visual field deficit, apraxia, expressive, receptive, or global speech impairment, altered intellectual ability, slow, cautious behavior. Right hemispheric stroke, paralysis or weakness on left side of the body, left visual field deficit, spatial perceptual deficit, increased distractibility, impulsive behavior and poor judgment, lack of awareness of deficits. Diagnostic investigation. Careful history, physical examination as well as neurological examination are important in detecting stroke. However, initial examination focuses on airway patency, which may be compromised by loss of gag or cough reflexes and altered respiratory pattern, cardiovascular status, blood pressure, cardiac rhythm, and rate carotid breaths, and gross neurological losses. Diagnostic investigations are described by Linda 2008 include computer tomography scan, cerebral angiography, electroencephalography. Several other imaging techniques are used along with computed tomography to gather more information about specific types of stroke. Magnetic resonance imaging uses a magnetic field to generate images of the human body and produces high-resolution images that are particularly useful in diagnosing brain vessel abnormalities that may be involved in a hemorrhagic stroke. In X-ray angiography, a dye injected into the bloodstream is viewed using X-ray to provide detailed images of blood vessels, enabling doctors to identify the source and location of an obstruction or gather anatomical information about aneurysms. Two other imaging techniques are single photon emission computed tomography, position emission tomography, involving injecting a radioactive substance into the bloodstream. As the substance travels through the circulatory system, it constantly emits radiation, which is collected by a radiation detector. The images produced enable doctors to see regions of the brain with abnormally low blood flow, indicating brain tissue that has been injured or damaged by a stroke. Other methods include carotid angiography, transcranial Doppler flow studies, esophageal echocardiography, position emission tomography. Management. Nursing management. Assessment or neurological assessment. Assessment findings depend on the area of the brain affected, changes in level of consciousness, signs of increased intracranial pressure should be noted. Assessment of cranial nerves 5, 7, 9, 10, and 12. Cranial nerve 5, difficulty with chewing. Cranial nerve 7, facial paralysis or paresis. Cranial nerve 9 and 10, dysphagia. Cranial nerve 9, absent gag reflex. Cranial nerve 12, impaired tongue movement. Airway patency is always a priority. Pulse may be slow and bounding. Blood pressure, hypertension, facial dropping. Warning signs of stroke. The acronym FAST is used to identify. Face. Ask the person to smile. Does one side of the face drop? Arms. Ask the person to raise both arms. Does one arm drift downward? Speech. Ask the person to repeat a simple sentence. Does the speech sound slurred or strange? Time. If you observe any of these signs independently or together, call 911 immediately. Interventions in aphasia. Provide repetitive direction. Break tasks down to one step at a time. Repeat names of objects frequently used. Allow time for client to communicate. Use a picture board, communication board, or computer technology. During acute phase of stroke, maintain a pathway airway and administer oxygen as prescribed. Monitor vital signs. Maintain a blood pressure of 150 to 100 mmHg to maintain cerebral perfusion. Suction secretions as prescribed, but never suction nasally or for longer than 10 seconds to prevent increasing ICP. Position the client on the side with the head of bed elevated 15 to 30 degrees as prescribed. Monitor level of consciousness, papillary response, motor and sensory response, cranial nervous function and reflexes. Maintain a quiet environment and carry out maintain handling of the client to prevent further bleeding. Prepare to administer anticoagulants, diuretics, antihypertensive and anticonvulsants as prescribed. Intervention in post-acute phase of stroke. Position the client 2 hours on the unaffected side and 20 minutes on the affected side. Provide skin, mouth and air care. Perform passive range of motion exercises to prevent contractions. Place anti-embolism stockings on the client. Monitor gag reflex and ability to swallow. Provide sips of fluid and slowly advance diet into foods that are easy to chew and swallow. Provide soft and semi-solid foods and flavored, cool or warm thickening food rather than thin liquid, because the stroke client can tolerate these types of food better. Speech therapists may do swallow studies to recommend consistency of food and fluids. When the client is eating, position the client sitting in a chair or sitting up in bed, while the head and neck position slightly forward and flexed. Place food in the back of the mouth on the unaffected side to prevent trapping of food in affected cheek. Interventions in chronic phase of stroke. Neglect syndrome. Client is unaware of the existence of his or her paralyzed side. Unilateral neglect, which places the client at risk for injury. Teach the client to touch and use both sides of the body. There's enough the visual field. Encourage the client to turn the head to scan the complete range of vision. Otherwise, he or she does not see half of the visual field. Approach the client from the unaffected side. Place the client's personal objects within the visual field. Provide eye care for visual deficits. Place a patch over the affected eye if the client has diplopia. Increase mobility as tolerated. Encourage fluid intake and high fiber diet. Administer stew softeners as prescribed. Encourage the client to express feelings. Encourage independence in activities of daily living. Assesses the need for assistive devices such as a cane, walker, splints, or braces. Teach transfer technique from bed to chair and from chair to bed. Provide GET training. Initiate physical and occupational therapy. Refer client to a speech and language pathologist as described. Medical or pharmacology management. Thrombolytic therapy. Thrombolytic agents are used to treat ischemic stroke by dissolving the blood clot that is blocking the blood flow to the brain. Recombinant TPA tissue type plasminogen activator is a genetically engineered form of TPA, a thrombolytic substance made naturally by the body. It works by binding to fibrin and converting plasminogen to plasmin, which stimulates fibrinolysis of the atherosclerotic lesion. Rapid diagnosis of stroke and initiation of thrombolytic therapy within 3 hours in patients with ischemic strokes leads to a disease, size of the stroke, and overall improvement in functional outcome after 3 months. Initial management requires the definitive diagnosis of an ischemic stroke by CT scanning and determination of whether the patient meets all the criteria for TPA therapy. Some of the contraindications for thrombolytic therapy include symptom onset greater than 3 hours prior to admission, a patient who is anticoagulated, a patient who has had a recent myocardial infarction, or a patient who has had any type of intracranial pathology, e.g. stroke, head injury, trauma. Once it is determined that the patient is a candidate for a TPA therapy, no anticoagulants are to be administered in the next 24 hours. Before receiving TPA, the patient should be assessed using the National Institute of Heart Stroke Scale, which contains 42 items evaluating neurologic deficits and is useful in differentiating between ischemic strokes and TIAs. A patient with an NIHSS score of greater than 22 is not eligible to receive TPA. To realize the full potential of thrombolytic therapy, community education directed at recognizing the symptoms of stroke and obtaining appropriate emergency care is necessary to ensure rapid transport to a hospital and initiation of therapy within the 3-hour time frame. Delays make the patient ineligible for thrombolytic therapy because revascularization of necrotic tissue, which develops after 3 hours, increase the risk for cerebral edema and hemorrhage. Dosage and administration. The patient is weighed to determine the dose of TPA. The minimum dose is 0.9 mg per kg. The maximum dose is 90 mg. The loading dose is 10% of the calculated dose and is administered over 1 minute. The remaining dose is administered over 1 hour via an infusion pump. After the infusion is completed, the line is flushed with 20 ml of normal saline solution to ensure that all the medication is administered. Side effects. Bleeding is the most common side effects of TPA administration, and the patient should be closely monitored for any bleeding. Intracranial, intravenous, insertion sites, urinary catheter site, endotracheal tube, nasogastric tube, urine, stool, emesis, and other secretions. Intracranial bleeding is a major complication that occurs in approximately 6.5% of patients. Not all patients are candidates for TPA therapy. Other treatments include anticoagulant administration, 4-heparin or low molecular weight heparin. For ischemic strokes and careful maintenance of cerebral hemodynamic to maintain cerebral perfusion, Increased intracranial pressure (ICP) and its associated complications may occur following a large ischemic stroke. Interventions during this period are methods to reduce ICP, such as administering an osmotic diuretic, e.g. mannitol, maintaining PaCO2 within the range of 30 to 35 mmHg, positioning to avoid aposia, transient ischemic attack. Patients with mild stroke from arterial fibrillation or from embolic or thrombotic causes are candidates for non-surgical medical management. Arterial fibrillation are treated with dose adjusted warfarin sodium. Platelet inhibiting medication, aspirin, dipridamole, ticlopidine, decrease incidence of cerebral infarction. Thrombolytic therapy are used to treat ischemic stroke by dissolving the blood clot that is blocking blood flow to the brain. Physiotherapy may restore lost movement or sensation. Speech therapy may help language disturbances. Carotid endarterectomy. This is a surgical intervention used in stroke management. It is targeted at stroke prevention, especially among clients with symptomatic carotid stenosis. A carotid endarterectomy is the removal of an atherosclerotic plaque or thrombus from the carotid artery to prevent stroke in patients with occlusive diseases of the extracranial cerebral arteries. This surgery is indicated for patients with symptoms of TIA or mild stroke found to be due to severe carotid artery stenosis or moderate stenosis with other significant risk factors. Nursing management during endarterectomy. The primary complications of carotid endarterectomy are stroke, cranial nerve injuries, infection or hematoma at the incision site. It is important to maintain adequate blood pressure levels in the immediate post-operative period. Hypotension is avoided to prevent cerebral ischemia and thrombosis. Uncontrolled hypertension may precipitate cerebral hemorrhage, edema, hemorrhage at the surgical incision, or disruption of the arterial reconstruction. Sodium nitroprusside is commonly used to reduce the blood pressure to previous levels. Close cardiac monitoring is necessary because these patients have a high incidence of coronary artery disease. A neurologic flow sheet is used to monitor and document all body systems with particular attention to neurologic status following carotid endarterectomy. The neurosurgeon is notified immediately if a neurologic deficit develops. Formation of a thrombus at the site of the endarterectomy is suspected if there is a sudden increase in neurologic deficit, such as weakness on one side of the body. The patient should be prepared for repeat endarterectomy. The patient should be prepared for repeat endarterectomy. Difficulty in swallowing, ulcers or other signs of cranial nerve dysfunction must be assessed. The nurse should focus on assessment of cranial nerve 6, 10, 11, 12. Some swelling in the neck after surgery is expected, if large enough. However, swelling and hematoma function can obstruct the airway. Emergency airway supplies, including those needed for a tracheostomy, must be available. Managing potential complications. Adequate cerebral blood flow is essential for cerebral oxygenation. If cerebral blood flow is inadequate, the amount of oxygen supplied to the brain will decrease and tissue ischemia will result. Therefore, maintaining cardiac output within the normal range of 4 to 8 liters per minute or sometimes greater can improve the cerebral blood flow and oxygen delivery. Adequate oxygenation begins with pulmonary care, maintenance of a patient's airway, and administration of supplemental oxygen as needed. Head injury. Any alteration in mental or physical functioning related to a blow to the head results into head injury. Among the major complications associated with head injury is increased intracranial pressure, Increased ICP is one of the most damaging aspects of brain trauma and other conditions. That was in 2005. ICP is very likely to cause severe harm if it rises too high. If it rises too high, an increase in pressure, most commonly due to head injury leading to intracranial hematoma or cerebral edema, can crush brain tissues, shift brain structures, contribute to hydrocephalus, cause the brain to innate and restrict blood supply to the brain. Epidemiology. In Nigeria, majority were males, 569, 7.61%, and in the 15 to 40 year age group, 376, 50.3% of the group, 376, 50.3%. Of the 537 causes of road accidents, those related to motorcycles were 367, 68.3%, motor vehicles 169, 31.5%, and bicycle 0.2%. And none of the motorcycle cases wore a protective helmet at the time of the accident. In the United States, 1.5 million individuals per year incur a head injury. Of the injuries, 75% are classified as mild. Between 1998 and 2000, the incidence of mild traumatic brain injury was 543 cases per 100,000 persons, with a doubling of these incidents in Native Americans and Nigeria. Pathophysiology of head injury. The skull protects the brain from trauma, but it does not absorb any of the impact from a blow. Direct blows may cause fracture of the skull. There can be a contusion or bruising and bleeding to the brain tissue directly beneath the injury site. However, the brain can bounce around inside the skull if it is subject to significant force, and because of this, the brain injury may not necessarily be located directly below the trauma site. A cortical injury describes this situation in which the initial blow causes the brain to bounce and is damaged by hitting the skull directly opposite the trauma site. Acceleration or deceleration and rotation are the common types of forces that can cause injuries away from the area of the skull that received the trauma. Classification of head injuries. Scalp laceration. Scalp laceration are the most minor type of head trauma because the scalp contains many blood vessels with constrictive ability. Most scalp laceration are associated with scalp laceration in infection. Skull fractures. Skull fractures frequently occur with head trauma. Fractures may be closed or open, depending on the presence of a scalp laceration or extension of the fracture into the ear, sinuses, or dura. The type and severity of a skull fracture depend on the velocity, the momentum, the direction of injury agents, and the site of impact. Minor head trauma. Brain injuries are categorized as being minor or major. Contusion. A sudden transient mechanical head injury with disruption of neural activity and a change in the level of consciousness is considered a minor head injury. The manifestation is usually of short duration. If the patient has not lost consciousness, or if the loss of consciousness lasts less than 5 minutes, the patient is usually discharged from the care facility with instruction to notify the healthcare provider if symptoms persist or if behavioral changes are noted. Major head trauma. Major head trauma includes cerebral contusions and lacerations. When major head trauma occurs, many delayed responses are seen, including hemorrhage, hematoma formation, seizure, and cerebral edema. Intracerebral hemorrhage is generally associated with cerebral laceration. This hemorrhage manifests as a space-occurring lesion accompanied by unconsciousness, hemiplegia or the contralateral side, and a dilated pupil on the ipsilateral side. As the hematoma expands, symptoms of increased ICP become more severe. Signs and symptoms. Prevention varies according to the injury. Some patients with head trauma stabilize and other patients deteriorate. A patient may present with or without neurologic deficits. Patients with concussion may have a history of seconds to minute unconsciousness than normal arousal. Disturbance of vision and equilibrium may also occur. Common symptoms of head injury include coma, confusion, drowsiness, personality change, seizures, nausea, and vomiting, headache, and a lucid interval, during which a patient appears conscious only to deteriorate later. Symptoms of skull fracture can include leaking cerebrospinal fluid. A clear fluid drainage from nose, mouth, or ear may be and is strongly indicative of basilar skull fracture and the tearing of sheaths surrounding the brain, which can lead to secondary brain infection. Visible deformity or depression in the head or face. For example, a sunken eye can indicate a maxillar fracture. An eye that cannot move or is deviated to one side can indicate that a broken facial bone is pinching a nerve that innervates eye muscles. Wounds or bruises on the scalp or face. Basilar skull fractures, those that occur at the base of the skull, are associated with battle sign, a subcutaneous bleed over the mastoid, hemotympanum, and cerebrospinal fluid, rhinorrhea, and otorrhea. Because brain injuries can be life-threatening, even people with apparently slightly injuries with no noticeable signs or complaints require close observation. They have a chance for severe symptoms later on. The caretaker of those patients with mild trauma who are released from hospital are frequently advised to rouse the patient several times during the next 12 to 24 hours to assess for worsened symptoms. The Glasgow Coma Scale is a tool for measuring degree of unconsciousness and is thus a useful tool for determining severity of injury. Skull fractures are described by which bone is broken, whether there is an associated laceration of the scalp, and whether the bone is depressed or potentially pushed into the brain tissue. Brain injury often occurs in combination with one another. The effects of brain injury depend upon the amount of brain tissue damage and the level of pressure within the skull and its effects on the brain. Causes of head injury. Common causes of head injury are motor vehicle traffic collisions, home and occupational accident, falls, assaults, bicycle accidents. Wilson disease has also been indicative of head injury. Head injury guidelines and assessments. Glasgow Coma Scale. The Glasgow Coma Scale was developed to provide a simple way for healthcare practitioners of different skill levels and training to quickly assess a patient's mental status and depth of coma based upon observation of eye-opening speech and movements. Patients in the deepest level of coma do not respond with any body movements to pain, do not have any speech, and do not open their eyes. Those in lighter comas may offer some responses to the point they may even seem awake, yet met the criteria of coma because they do not respond to their environments. A person who is awake has a Glasgow Coma Scale of 15, while a person who is dead will have a score of 3. The abnormal motor responses of flexion and extension describe arm and leg movements when a painful stimulus is applied. Trauma patients are often touched by many healthcare practitioners, from first responders, emergency physicians, surgeons, and neurosurgeons. Not only is it important to assess the depth of coma, but also to know if the patient is improving or deteriorating. The scale is used as part of the initial evaluation of a patient, but does not assist in making the diagnosis as to the cause of coma. Since it scores the level of coma, the GCS can be used as standard method for any healthcare practitioner to assess change in patient status. Imaging. Different forms of imaging modalities such as X-rays demonstrate presence of fractures in the neck and skull. Computed tomography (CT scan) reveals presence of bone or skull fractures, bleeding, hematoma, inflammation of the brain, and brain tumors. Magnetic resonance imaging, used in assessing the extent of head injury and damage to the brain and other vital organs. Others are cerebral angiography, electroencephalography, transcranial transcranial Doppler ultrasound, and single photon emission computed tomography. Medical management. The treatment of head injury may be divided into treatments of closed head injury and the treatment of penetrating head injury. While significant overlap exists between the treatment of these two types of injury, some important differences are discussed. Closed head injury treatment is divided further into the treatment of mild, moderate, and severe head injuries. Mild head injuries. Most head injuries are mild head injuries. Most people presenting with mild head injuries will not have any progression of their head injury. However, up to 3% of mild head injuries progress to more serious injuries. Mild head injuries may be separated into low risk and moderate risk groups. Patients with mild to moderate headache, dizziness, and nausea are considered to have a low risk injuries. Many of these patients require only minimal observation after they are assessed carefully, and many do not require radiographic evaluation. These patients may be discharged if a reliable individual can monitor them. Patients who are discharged after mild head injury should be given an instruction sheet for head injury care. The sheet should explain that the person with the head injury should be awakened every 2 hours and assessed neurologically. Caregivers should be instructed to seek medical attention if patients develop severe headache, persistent nausea and vomiting, seizures, confusion or unusual behavior, or watery discharge from either the nose or the ear. Patients with mild head injuries typically have concussions. A concussion is defined as a physiological to the brain without any evidence of structural alteration. Concussions are graded on a scale of 1 to 5. A grade of 1 concussion is one in which a person is confused temporarily but does not display any memory changes. In a grade 2 concussion, brief disorientation and anterograde amnesia of less than 5 minutes duration are present. In a grade 3 concussion, retrograde amnesia and loss of consciousness for less than 5 minutes are present, in addition to 2 criteria for a grade 2 concussion. Grade 4 and 5 concussion are similar to a grade 3, except that in grade 4 concussion, the duration of loss of consciousness is 5 to 10 minutes. In a grade 5 concussion, the loss of consciousness is longer than 10 minutes. After a mild head injury, those displaying persistent emesis, severe headache, anterograde amnesia, loss of consciousness, or signs of intoxication by drugs or alcohol are considered to have a moderate risk head injury. These patients should be evaluated with a head CT scan. Patients with moderate risk mild head injuries can be discharged if their CT scan findings reveal no pathology, their intoxication are clear, and they have been observed for at least 8 hours. Moderate and severe head injury. The initial resuscitation of a patient with a head injury is of critical importance to prevent hypoxia and hypotension. In the traumatic coma data bank study, patients with head injury who presented to the hospital with hypotension had twice the mortality rate of patients who did not present with hypotension. The combination of hypoxia and hypotension resulted in a mortality rate 2.5 times greater than if neither of these factors was present. Once the patient has been stabilized from the cardiopulmonary standpoint, evaluation of their neurologic status may begin. The initial GCS score provides a classification system for patients with head injuries but does not substitute for a neurologic examination. After assessment of the common score, a neurologic examination should be performed if a patient has received muscle relaxant. If a patient has received muscle relaxant, the only neurologic response that may be evaluated is the pupillary response. If a surgical lesion is present in the CT scan results, arrangements are made for immediate transport to the operating room. Fewer than 10% of patients with TBI have an initial surgical lesion. Sedation is often necessary in patients with traumatic injury. Some patients with moderate head injuries have significant agitation and require sedation. In addition, patients with multisystem trauma often have painful systematic injuries that require pain medication, and many intubated patients require sedation. Short-acting sedative and analgesic should be used to accomplish proper sedation without eliminating the ability to perform periodic neurologic assessments. This requires careful titration of medication doses and periodic weaning or withholding of sedation to allow periodic neurologic assessment. Intravenous lidocaine administered along with rapid sequence induction before endotracheal intubation is not associated with significant hemodynamic changes in traumatic brain injury patients. The use of anticonvulsants in patients with TBI is a controversial issue. No evidence exists that the use of anticonvulsants decreases the incidence of late-onset seizures in patients with either closed head injury or TBI. After instituting general supportive measure, the issue of ICP monitoring is addressed. ICP monitoring has consistently been shown to improve outcome in patients with head injuries. ICP monitoring is indicated for any patients with a GS score less than 9, any patients with head injury who requires prolonged deep sedation or pharmacologic relaxant for a systemic condition, or any patients with an acute head injury who is undergoing extended general anesthesia for a non-neurosurgical procedure. Increased intracranial pressure will be acutely managed. Other supportive treatments while awaiting possible operative therapy. Other supportive treatments are as follows. Early extraventricular drainage of CSF is sometimes of value in controlling brain edema if there is a suspicion that the ventricles will progressively diminish in size because edema cannot be cannulated from a borehole. Coughing and straining increase venous pressure, restricting drainage and blocking of blood into the head, thereby increasing ICP. Neuromuscular paralysis may decrease ICP by preventing sudden changes related to coughing or straining and by promoting systemic venous pooling that increases venous drainage from the head. Any other restrictions to jugular blood drainage, such as a neck from positioning in bed, increase ICP by retarding jugular drainage, transmitting pressure back into the brain. Trying to differentiate a drug-induced coma from an increased ICP-induced coma with a trial of naloxone, Narcan, is contradicted, as it is invariably induces agitation if the stupor is narcotic-induced. Agitation increases catechocalamine response, increases cardiac output, and increases blood flow to the head, thereby increasing hydrostatic pressure and ICP. Decreased serum protein albumin from malnutrition causes decreased serum osmolality compared to the osmolality in the surrounding tissue. This allows intravascular water to flow along the increased osmotic gradient into the tissues. Increasing edema. Hyperalimentation should be initiated as soon as possible if the cause is likely to be protracted. Boutique intravenous stabilizing cocktails have been said to maintain homeostasis of intravascular and extravascular fluid compartments, avoiding rapid fuel shifts that might adversely affect cerebral metabolism and edema. Composed of an albumin, bicarbonate, and laxative solution, the albumin increases intravascular coiled content, resisting fluid flow into the brain substance. The bicarbonate buffer's pH changes, and the laxative tends to promote a stable, consistent urine output, resisting intravascular fluid changes from renal compensations. This may be useful in diffuse brain edema to protect against further damage from vascular compartment shift, but body physiology probably adapts to it rapidly, thereby limiting its effect. These cocktails have not been proven to be effective as a treatment of SAH since they tend to promote diuresis and intravascular depletion. Penetrating trauma. The treatment of penetrating brain injuries involves two main aspects. The first is the treatment of the traumatic brain injury (TBI) caused by a penetrating object. Penetrating brain injuries, especially from high-velocity missiles, frequently result in severe ICP elevations. This aspect of penetrating brain injury treatment is identical to the treatment of closed head injuries. The second aspect of penetrating head injury treatment involves debridement and removal of the penetrating objects. Penetrating injuries require careful debridement because these wounds are frequently dirty. When objects penetrate the brain, they introduce pathogens into the brain from the scalp surface and from the surface of the penetrating object. Penetrating injuries may be caused by high-velocity missiles, e.g. bullets, penetrating objects, e.g. knives, tools, or fragments of bones driven into the brain. Bullet wounds are treated with debridement of as much of the bullet trace as possible. Dura closure and reconstruction of the scars as needed. If the bullet can be removed without significant risk of neurologic injury, it should be removed to decrease the risk of subsequent infection. Penetrating objects such as knives requires removal to prevent further injury and infection. If the penetrating object either is near or transverse, a major vascular structure, an angiogram is necessary to assess it for potential vascular injury. When the risk of vascular injury is present, penetrating objects should be removed only for appropriate access has been obtained to ensure the vascular control is easily achieved. Penetrating brain injuries are associated with high rates of infection, both early infections and delayed abscesses. Appropriate debridement and irrigations of wound helps to decrease the infection rate. Some of the risk factors for infection following penetrating brain injury include extensive bone destruction, persistent CSF leak, and injury pathway that violates and near sinus. Complication. Functional deficits resulting from TBI are common and can be divided into two categories as follows: systemic complication and neurologic complication. The systemic complications of TBI are typical of any severe injury and depend on the type of intensive treatment used. Be aware of the complications of intensive care treatment when considering systemic complications of head injury. The neurologic complications of TBI include focal neurologic deficits, global neurologic deficits, seizures, CSF fistulae, hydrocephalus, vascular injuries, infections, and brain deaths. Nursing management. The nursing interventions for the patients with a head injury are extensive and diverse. They include making nursing assessments, setting priorities for nursing interventions, anticipating needs and complications, and initiating rehabilitation. Monitoring for declined neurologic function. The importance of ongoing assessment and monitoring of brain-injured patients cannot be overstated. The following parameters are assessed initially and as frequently as the patient's condition requires. As soon as the initial assessment is made, the use of neurologic flowchart is started and maintained. Level of consciousness. The LOC is regularly assessed because changes in it precede all other changes in vital and neurologic signs. The Glasgow Coma Scale, which is used to assess LOC, is based on the criteria of eye opening, verbal responses, and motor responses to verbal commands or painful stimuli. It is particularly useful for monitoring changes during the acute phase, the first few days after a head injury. It does not take the place of an in-depth neurologic assessment. Rather, it is used to monitor the patient's motor, verbal, and eye-opening responses. The patient's best responses to predetermined stimuli are recorded. Each response is scored. The greater the number, the better the functioning. And the sum of these scores gives an indication of the severity of coma and a prediction of possible outcome. The lowest score is 3, least responsive. The highest is 15, most responsive. A score of 8 or less is generally accepted as indicating a severe head injury. Vital signs. Although a change in LOC is the most sensitive neurologic indication of deterioration of the patient's condition, vital signs are monitored at frequent intervals also to assess the intracranial status. Signs of increasing ICP include slowing of the heart rate, bradycardia, increasing systolic blood pressure, and widening pulse pressure. As brain compression increases, respiration becomes rapid. The blood pressure may decrease and the pulse slows further. A rapid rise in body temperature is regarded as unfavorable because hyperthermia increases the metabolic demands of brain and may indicate brainstem damage. A poor prognostic sign. The temperature is maintained at less than 38 degrees Celsius. Tachycardia and arterial hypotension may indicate that bleeding is occurring elsewhere in the body. Motor function. Motor function is assessed frequently by observing spontaneous movements, asking the patient to rise and lower the extremities, and comparing the strength and equality of the hand grabs and pedal push at periodic intervals. To assess this Glasgow Coma Scale is used. Other neurologic signs. The size and equality of the pupils and their reaction to light are assessed. A unilateral dilated and purely responding pupil may indicate a developing hematoma with subsequent pressure on the third cranial nerve due to shifting of the brain. If both pupils become fixed and dilated, this indicates overwhelming injury and intrinsic damage to the upper brainstem and is a poor prognostic sign. The patient with head injury may develop focal nerve palsies such as anosmia, lack of sense of smell, or eye movement abnormalities, and focal neurologic deficits such as aphasia, memory deficits, and post-traumatic seizures or epilepsy. Maintaining the highway. One of the most important nursing goals in the management of the patients with head injury is to establish and maintain an adequate highway. The brain is extremely sensitive to hypoxia, and the neurologic deficits can worsen if the patient is hypoxic. Therapy is directed towards maintaining optimal oxygenation to preserve cerebral function. An obstructed highway causes CO2 retention and hypoventilation, which can produce cerebral vasodilation and increased ICP. Interventions to ensure an adequate exchange of air include the following. Keep the unconscious patient in a position that facilitates drainage of oral secretions, with the head of the bed elevated about 30 degrees to decrease intracranial venous pressure. Establish effective suctioning procedures. pulmonary secretions produce coughing and straining, which increase ICP. Guard against aspiration and respiration insufficiency. Closely monitor arterial blood gas values to assess the adequacy of ventilation. Monitor the patient who is receiving mechanical ventilation. Monitor for pulmonary complications such as acute respiratory distress syndrome and pneumonia. Monitoring fluid and electrolyte balance. Brain damage can produce metabolic and hormonal dysfunctions. The monitoring of serum electrolyte level is important, especially in patients receiving osmotic diuretics. Those with inappropriate antidiuretic hormone secretion and those with post-traumatic diabetes insipidus. Increasing lethargy, confusion, and seizures may be due to electrolyte imbalance. Endocrine function is evaluated by monitoring serum electrolytes, blood glucose value, and intake and output. Urine is tested regularly for acetone. A record of daily weight is maintained, especially if the patient has hypothalamic involvement and is at risk for the development of diabetes insipidus. Promoting adequate nutrition. Head injury results in metabolic changes that increase calorie consumption and nitrogen excretion. There is an increased demand for protein. As soon as possible, nutrition should be provided. Early initiation of nutritional therapy has been shown to improve outcomes in head-injured patients. If there is discharge of CSF from the nose, an oral feeding tube should be inserted in place of a nasal tube. Laboratory values should be monitored closely in patients receiving parenteral nutrition. Elevating the head of the bed and aspirating the enteral tube for evidence of residual feeding before administering additional feeding can help prevent distension, regurgitation, and aspiration. Enteral or parenteral feedings are usually continued until the swallowing reflex returns and the patient can meet caloric requirements daily, preventing injury. The patient emerging from a coma may become increasingly agitated toward the end of the day. Restlessness may be due to hypoxia, fever, pain, or full bladder. It may indicate injury to the brain, but may also be a sign that the patient is regaining consciousness. Some restlessness may be beneficial because the lungs and extremities are exercised. Agitation may also be due to discomfort from catheters, intravenous lines, restraints, and repeated neurologic checks. Alternatives to restraints must be used whenever possible. Strategies to prevent injury include the following: assess the patients to ensure the oxygenation is adequate and the bladder is not distended. Check dressings and casts for constriction. To protect the patient from self-injury and dislodging of tubes, use parted side rails or wrap the patient's hand in mitts. Restraints are afforded because straining against them can increase ICP or cause other injury. Enclosed or flow-level specialty belts may be indicated. Avoid using opioids as means of controlling restlessness because these medications depress respiration, constrict the pupils, and alter responsiveness. Minimum environmental stimuli by keeping the room quiet, limiting visitors, speaking calmly, and providing frequent orientation formation, e.g. explaining where the patient is and what is being done. Provide adequate lighting to prevent visual or hallucinations. Minimal disruption of the patient's sleep or wake cycles. Lubricate the skin with oil or emollient lotion to prevent irritation due to rubbing against the sheets. If incontinence occurs, consider use of an external sheath catheter or a male patient because prolonged use of an indwelling catheter inevitably produces infection. The patient may be placed on an intermittent catheterization schedule. Maintaining skin integrity. Patients with traumatic head injury often require assistance in turning and positioning because of immobility or unconsciousness. Prolonged pressures on the tissues will decrease circulation and lead to tissue necrosis. Potential areas of breakdown need tube. Potential areas of breakdown need tube Identify early to avoid development of pressure ulcers. Special nursing measures include the following: assesses all the body surface and documents skin integrity at least every 8 hours. Turn and reposition the patient every 2 hours. Provide skin care every 4 hours. Assist patient to get out of bed to a chair 3 times a day if physically able. Improving cognitive functioning. Cognitive impairment includes memory deficits, decreased ability to focus and sustain attention to a task, distractibility, reduced ability to process information, and slowness in thinking, perceiving, communicating, reading, and writing. A neuropsychologist, a specialist in evaluating and treating cognitive problems, plans a program and initiates therapy or counseling to help the patient reach maximum potential. Cognitive rehabilitation activities help the patient to devise new problem-solving strategies. Supporting family coping. Having a loved one sustaining a serious head injury can produce a great deal of prolonged stress in the family. Families report difficulties in coping with changes in the patient's temperament, behavior, and personality. Such changes are associated with disruption of family cohesion, loss of leisure pursuits, and loss of work capacity, as well as social isolation of the caretaker. Family counseling helps address the family members' overwhelming feelings of loss and helplessness and give them guidance for the management of inappropriate behaviors. Support groups helps the family members share problems, develop insights, gain information, network, and gain assistance in maintaining realistic expectation and hope. Headaches. Headache or cephalgia is one of the most common of all human physical complaints. Headache is actually a symptom rather than a disease entity. It may indicate organic disease, neurologic or other disease, a stress response, vasodilation, migraine, skeletal muscle tension, headache, or a combination of factors. Headache is a pain within the cranial vault. EK 2007. Types of headaches: primary headaches, secondary headaches. A primary headache is one for which no organic cause can be identified. This type of headache include migraine, tension type, and cluster headaches. Link 2001. A secondary headache is one associated with an organic cause such as aneurysm and brain tumors. Most headaches do not indicate serious disease, although persistent headaches require further investigation. Serious disorders related to headache include brain tumors, subarachnoid hemorrhage, stroke, severe hypertension, meningitis, and head injuries. Migraine. Migraine is a symptom complex characterized by periodic and recurrent attacks of severe headache. The cause of migraine has not been clearly demonstrated, but it is primarily a vascular disturbance that occurs most commonly in women and has a strong familial tendency. The typical time of onset is puberty, and the incidence is highest in adults 20 to 35 years of age. There are 7 subtypes of migraine, including migraine with and without aura. Most patients have migraine without an aura. Clinical manifestations of migraine. The migraine with aura can be divided into 4 phases: prodrome, aura, the headache, and recovery. Headache and termination, and postdrome. Prodrome. The prodrome phase is experienced by 60% of patients with symptoms that occurs hours to days before a migraine headache. Symptoms include depression, irritability, feeling cold, food cravings, anorexia, change in activity level, increased urination, diarrhea, or constipation. Patients usually experience the same prodrome with each migraine headache. Aura phase. Aura occurs in up to 31% of patients who have migraines. Guatsby 2002. The aura usually lasts less than an hour, and many provide enough time for the patient to take the prescribed medication to avert a full-blown attack, described in a later section. This period is characterized by focal neurologic symptoms. Visual disturbances, that is, light flashes and bright spots, are common and may be hemianopic, affecting only half of the visual field. Other symptoms that may follow include numbness and tingling of the lips, face or hands, mild confusion, slight weakness of an extremity, drowsiness and dizziness. This period of aura corresponds to the painless vasoconstriction that is the initial physiologic change characteristics of classic migraine. Cerebral blood flow studies performed during migraine headaches demonstrate that during all phases of the attack, cerebral blood flow is reduced throughout the brain with subsequent loss of autoregulation and impaired CO2 responsiveness. Headache phase. As vasodilation and a decline in serotonin level occur, a throbbing headache on unilateral in 60% of patients intensifies over several hours. This headache is severe and incapacitating and is often associated with photophobia, nausea and vomiting. Its duration varies, ranging from 4 to 72 hours. Recovery phase. In the recovery phase, termination and postdrome, the pain gradually subsides. Muscle contraction in the neck and scalp is common, with associated muscle ache and localized tenderness. Exhaustion and mood changes. Take 2. Any physical exertion exacerbates the headache pain. During this post-headache phase, patients may sleep for extended period. Tension headaches. This is also known as muscle contraction headaches. They are the most common form of headache. It is characterized by a steady, constant feeling of pressure that usually begins in the forehead, temple, or back of the neck. Cluster headache. They are unilateral headache that come in clusters of 1 to 8 days. Take 2. 1 to 8 daily. The pain is localized to eye and orbits and radiates to facial and temporal region. It is also accompanied by watering of the eye and nasal congestion. Cluster headache usually lasts 15 minutes to 30 hours. They are seen 5 times more frequently in men than women. Pathophysiology of headache. Pain-sensitive structures, skin, muscle, peristernum, cerebral vessels, nasal cavity, and sinuses within the cranial vault are sensitive to pain. Stretching, inflammation, pressure, compression, and dilation of the pain. Sensitive structures can produce the trembling, which results in headache. Assessment and diagnostics evaluation. The diagnostic evaluation includes a detailed history taking, a physical assessment of the head and neck, and a complete neurologic examination. Patients are asked to describe headaches. Management of headache. Abortive management. Drugs are used to reduce frequency and severity of the headache. Metaguide mallets, serotonin antagonist and vasoconstrictor, propranolol, androchloride, and hydrochloride, beta blocker preventing vasodilation, non-narcotic analgesics such as aspirin and acetaminophen, tranquilizers like diazepam to relieve muscle tension. Preventive management. Prevention begins by having the patient avoid specific triggers that are known to initiate the headache syndrome. Preventive medical management of migraine involves the daily use of one or more agents that are thought to block the physiologic events leading to an attack. Medication therapy should be considered for migraine if attacks occur 3 to 4 days per day. Treatment regimens vary greatly, as do patient responses. Thus, close monitoring is indicated. There are several proven or widely used medications for the prevention of migraine. 2 beta-blocking agents, propranolol, Indera, and metoprolol, inhibit the actions of beta receptors, cells in the heart and brain that controls the dilation of blood vessels. This is thought to be a major reason for their anti-migraine action. Other medications that are prescribed for migraine prevention include amitriptyline, hydrochloride LV, Davapro, valproate, flunarizine, and several serotonin antagonists. Calcium antagonists, verapamil HCI, are widely used but may require several weeks at a therapeutic dosage before improvement is noted. Calcium channel blockers are not as effective as beta blockers for prevention, but may be more appropriate for some patients, such as those with bradycardia, diabetes mellitus, or asthma. Alcohol, nitrites, vasodilators, and histamides may precipitate cluster headache. Getting these factors helps in preventing the headaches. Prophylactic medication therapy may include beta blockers, ergotamine occasionally, lithium, nitrous nitrosamine, and methotrexate. Such therapy is effective in 20% to 40% of cases. Hypothetical case study of Mr. S.A. with ischemic stroke. Mr. S.A., a 57-year-old man, was rushed to the hospital by his wife with complaints of numbness of the entire right side of the body, confusion, and difficulty understanding speech. A diagnosis of ischemic stroke was made after nursing assessment. Assessment revealed decreasing level of consciousness, evidenced by decreasing GS score. Client's past health history showed a history of primary hypertension, a positive family history of stroke, activity exercise pattern, loss of movement and sensation, syncope, weakness on one side and generalized weakness, cognitive perceptual, numbness, tingling on one side of the body, objective data, loss of cough reflex, labored respiration, trachea, cardiovascular, labored respiration, trachea, cardiovascular, hypertension, tachycardia. Nursing diagnosis. The following nursing diagnoses were identified: ineffective cerebral tissue perfusion related to decreased cerebral blood flow, secondary to thrombus, evidenced by decreasing Glasgow Coma scale; ineffective airway clearance related to inability to raise secretions, as evidenced by diminished breath sounds and ineffective cough; impaired physical mobility related to numbness of the entire right side of his body, evidenced by decreased physical activity; risks for impaired skin integrity related to decreased mobility. Study section summary. In this study section, you learned that neurologic disorders are debilitating conditions that reduce the quality of life of clients. Nursing intervention should be aimed at restoring optimal functioning, thereby improving the quality of life of these clients. Also, education about prevention and risk factors of these disorders go a long way in reducing the incidences. We've come to the end of study section 4. Thank you for listening.